Divyashree is going to present on exudative variant.
Good morning, everyone. Thank you, AIOS, for this wonderful opportunity. So I'll be presenting about the exudative variant posterior sympathetic ophthalmia, presenting with basilar layer detachment. A 30-year-old male patient presented with history of painless loss of vision since 3 days in his right eye, and he had sustained a penetrating ocular injury to his left eye and had undergone corneoscleral tear repair a month back. At presentation, his vision in right eye was counting fingers close to face, and left eye had no perception of light and was in pre-phthalmic stage. His anterior segment examination of right eye showed presence of circumciliary congestion. Cornea was normal, with normal anterior chamber depth with cells of 2+, and pupil was sluggishly reactive. IOP was 20 millimeters of mercury, and anti-vitreous phase showed 1 to 5 cells. And examination of the left eye, he had circumciliary congestion, sutured corneal tear, and shallow PACD with hyphema, and due to which the rest of the details was not able to assess. So this is the colored fundus photograph of his right eye, showing a normal optic disc with multiple yellowish patchy area in the retinal background with loss of foveal reflex. And when the fundus fluorescent angiography was done, there is multiple hyperfluorescent lesions were seen, which increases in size and intensity in the subsequent plates. So when the OCT was done, this shows the picture of optic disc and the macula. There is a large series elevation of the retina and intraretinal split with hyperreflective echoes, and there is disruption of the myoid zone and accumulation of the fluid in between them with the detachment of the ELM, showing as bacillary layer detachment. So looking at his history and presentation, we diagnosed him to be as having sympathetic ophthalmia in the right eye, and we evaluated him for any contraindication for the steroid management or the immunosuppressant, and we started him immediately on IV methylprednisolone for up to 3 days, followed by oral steroids for up to 2 weeks, supported with methotrexate of 15 milligrams per week with folic acid. So these are the subsequent visits that he had, and the OCT scans showing the resolution of the subretinal fluid in the OCT scans. So at the end of 3 months follow-up, we came to know that his vision was good enough, which was 6/9 N6, and inflammation was cleared and exudation had resolved. Discussion: though the anterior chamber and anterior segment inflammation is seen predominantly in sympathetic ophthalmia, our case had predominant posterior segment involvement, and imaging of severe exudation shows characteristic bacillary layer detachment recently, which is described in with HD OCT in uveitic conditions as seen in our case. Starting on early treatment like IV steroids and immunomodulators helps in gaining back the vision to 6/9 at the end of 3 months. Conclusions: severe exudative form manifests early in the course of disease. Advent of newer investigating modalities like OCT aids in diagnosing and serial monitoring of its resolution with the treatment. And these are my references. Thank you.
That's a good paper. How long is your follow-up? 3 months?
Mom, actually, it was very sad to see that he had actually succumbed to death due to the COVID. So we could hardly follow him up to 3 to 4 months.
Oh, okay.
Nice presentation, Dr. Divyashree. Just one comment technically. The patient's details should be de-identified. You have cropped all these images, but the MR number and part of the name we can see from the images. So you have to take care of that. Okay.
Sure, sir.
Otherwise, nice presentation. Thank you.
Thank you.